afternoon, and welcome to the 2017 ASCO Annual Meeting Presscast. We will now turn the conference over to your moderator, Dr. Richard Shelsky. Please go ahead.
Thank you, and welcome everyone. Thanks for joining the 2017 ASCO Annual Meeting Presscast. I'm Dr. Richard Shelsky. I'm the Chief Medical Officer at ASCO, and I will be moderating today's Presscast. Joining me on today's call is ASCO President Dr. Dan Hayes and President-elect Dr. Bruce Johnson. Today we're going to highlight 6 important studies that span the spectrum of patient care from prevention to treatment to survivorship. This research was drawn from the 5,000 or so abstracts that will be presented or published as part of ASCO's 53rd annual meeting. The vast majority of these abstracts will be publicly released online today at 5 p.m. Eastern Time. As a reminder, everyone on this call has signed an agreement to abide by ASCO's confidentiality and embargo policies, and your participation in today's Presscast is contingent upon that agreement. All of the studies featured in today's Presscast will also be presented at the ASCO annual meeting, being held Friday, June 2nd through Tuesday, June 6th at the McCormick Place Convention Center in Chicago. Other major research designated as late-breaking abstracts that includes studies selected for the meeting's plenary session will be released on a rolling basis throughout the meeting. We encourage you to visit the annual meeting Media Resource Center at asco.org/AMMRC to review the timetable of on-site embargoes. We will hold a question and answer session following the author presentations today. However, if you need further information or would like to set up an interview with one of the authors after the Presscast, please contact the ASCO media team directly at mediateam@asco.org. For general consumer information about cancer types and treatments, we refer you to ASCO's patient information website, cancer.net, where you'll find information on more than 120 different types of cancer. As doctors, we routinely refer our patients, their families, and caregivers to cancer.net because it's got helpful, easy-to-understand information about cancer that is reviewed and recommended by the nation's leading oncologists. So before we introduce our study authors, Dr. Johnson will provide a brief preview of the on-site press conference schedule, and Dr. Hayes will provide an overview of this year's annual meeting. So, Dr. Johnson, I'll hand it over to you.
Thank you, Dr. Shelsky. In addition to today's Presscast, we will hold press briefings each day in Chicago. The studies included in these press briefings highlight promising new research on a variety of topics, such as liquid biopsy, targeted therapy, immunotherapy, and quality of life issues, among many other research findings from the field. We'll kick off the annual meeting with our first News of the Day press briefing on Friday, June 2nd at 1 p.m. Central Time. And on Saturday, June 3rd, we'll hold 3 different briefings. The first will be at 8 a.m. Central Time. The second will follow at 11 a.m. In addition to featuring News of the Day, the second briefing will also include a brief presentation by Dr. Sid Mukherjee on his latest book, The Gene, An Intimate History. Dr. Mukherjee, who is a keynote speaker at this year's meeting, will deliver the ASCO special lecture early in the day. Our final briefing on Saturday will take place at 1 p.m. Central Time. In this briefing, CancerLink will announce 2 key collaborations, provide an update on the project's latest progress. On Sunday, June 4th, we'll hold 2 briefings. The first is research on ASCO's plenary session, which is going to be featured at the 8 a.m. briefing. And then at 11 a.m., we'll hold a briefing on ASCO's international efforts. We hear from ASCO volunteers about the Society's efforts to support individual physicians, quality improvement, and advance cancer care globally. And lastly, on Monday, June 5th, our press briefing will take place at 8 a.m. I'll now turn over the call to ASCO's current president, Dr. Daniel Hayes.
Thank you, Dr. Johnson, and welcome everybody. We're really pleased to have you on this call. We're anticipating 38,000 oncology professionals to attend our annual meeting in the first weekend of June. They come from all around the world, and they are obviously coming to discuss our new state-of-the-art treatment modalities, our new therapies, and frankly, ongoing controversies in the field as well. There have been a number of areas of progress in the field of cancer care, and that's led to what we believe will be a very exciting program for 2017. We've really had remarkable diversity in a variety of advances for patients, including issues related to survivorship and psychological interventions, which we believe in many respects reflects the maturity of our field as we've gotten into more and more survivors. It's estimated there'll be 15 million cancer survivors in the United States this year. Also, there have been studies illustrating how precision medicine continues to advance and deliver on its promise. And we're also excited about ongoing progress in immunotherapy for cancers as well. My theme for this year's annual meeting has been making a difference in cancer care with you, which we believe is what ASCO's main goal is to do. I selected this because we really are uniquely positioned as the world's largest professional society for cancer to bring the brightest minds of oncology research, education, and care into a single community. And our overall goal, of course, is to benefit patients with cancer everywhere in the world. Having said that, we're excited, and we'd like to introduce our speakers now so that they can go through some of the exciting abstracts we have to present to you. So it's my pleasure to welcome each of these distinguished researchers on the call. Dr. Aaron Van Blerigan, Dr. Timidayo Fadalu, Dr. John Primrose, Dr. Yilong Wu, Dr. Yusong Han, and Dr. Maura Gillison. Each of these researchers will have the opportunity to present their findings to you, and then we'll open the lines for discussions. So please hold your questions until we announce if the lines are open. Our first presentation will detail the results of an analysis evaluating the impact of a healthy lifestyle, including nutrition and physical activity on colon cancer survival. So I'd like to introduce Dr. Van Blerigan, who's an assistant professor of epidemiology and biostatistics at the University of California, San Francisco, to present the findings. Dr. Van Blerigan?
Thank you, and thank you for giving me this opportunity to present our work. You can go to the next slide. So there are over 1.3 million people who've been diagnosed with colorectal cancer in the United States. These individuals often seek information on what they can do to lower their risk of cancer recurrence, including asking for guidance on lifestyle. In response to patient interest in the need for improved survivorship care, the American Cancer Society published guidelines on nutrition and physical activity. These were first published in 2001 and last updated in 2012. The guidelines are based on published scientific studies, but it's not actually known if patients who follow the guidelines after diagnosis live longer. Therefore, we sought to determine whether colon cancer patients whose lifestyle was consistent with the guidelines had longer disease-free, recurrence-free, and overall survival. Go to the next slide. So we did this prospective study of 992 colon cancer patients who were participating in a nationwide randomized controlled trial of adjuvant chemotherapy. Patients were enrolled in the trial within 8 weeks of their colon cancer surgery, and then at enrollment, they received 6 months of chemotherapy. They also completed comprehensive validated surveys at 2 time points, at the start of the study and 6 months after completing their therapy. All the patients were followed through 2009 to determine who experienced cancer recurrence or died. And the median follow-up was 7 years. During that time, 335 people had cancer recurrence and 299 people died. Many of those deaths were due to colon cancer and reflective of the cancer recurrence numbers. And the primary, as I mentioned, the primary cause of death was colon cancer. Next slide. So this slide is long, and I'll go through slowly, but to show you how we quantified patients' adherence to the guidelines, we used a previously published score developed by researchers at the American Cancer Society. The table shows you the recommendation in the left column and the score that patients received in the right column. The overall score ranges from 0 to 6, with higher numbers corresponding to greater adherence. You can do next, So for the first factor was achieving and maintaining a healthy body weight. So patients received a score of 0 if they have a BMI or body mass index of 30 or more, which corresponds to being obese, and a score of 2 score if they have a BMI of 18.5 to 24.9, which is normal weight. So next. So the second recommendation is to engage in regular physical activity. And this is used with a MET value, which corresponds to the amount of energy a particular exercise requires relative to your resting metabolic rate. For the score categories, the optimal level corresponds to walking briskly for 1 hour, 5 days per week. Individuals walking less than 30 minutes per day on 5 days per week received a 0. So the third component of the score is diet, which is a bit more complex. So there's actually a sub-score that I'm going to describe in the next slide. But the optimal score was given to people consuming a variety of vegetables and fruits, whole grains, and avoiding red and processed meats. So these three factors on top are summed to create the overall score. In addition, alcohol, it was included in the guidelines through 2006. It was not included in 2012 because the experts felt that it should be customized to individual cancer survivors. However, we considered the score both with and without alcohol. Now, to get an optimal score was given to people with low to moderate intake, which is defined as up to 1 per day for women and 2 per day for men. Please note that the alcohol score is bimodal, where heavy drinkers receive a score of 0, abstainers receive a score of 1, and the low to moderate intake is the optimal of 2. So next, actually I should have said that sooner, so go ahead and go forward. And so these are our primary results. Applying this score, we observed that colon cancer patients with higher lifestyle scores had statistically significant lower risk of death than those with low scores. If you first focus on the graph on the left, the x-axis is the guideline score with, as I said, 0 is no adherence, 6 is high adherence. The y-axis is the hazard ratio, which is a measure of the relative risk of recurrence and death. And individuals with a score of 0 or 1 were used as the reference. In this case, 26% of our patients had a score of 0 or 1. We observed that patients with a score of 5 to 6 had a 42% lower risk of death compared to those with a score of 0 or 1. Only 9% of patients had a score of 5 to 6. The figure on the right represents the results including alcohol in the score. So the score now ranges from 0 to 8, with 8 representing people with full compliance to the guidelines. We observed that individuals with a score of 6 to 8 had a 51% lower risk of death than those with a score of 0 to 2. And here, 16% of patients had a 6 to 8, compared to 19% of patients with a score of 0 to 1. Next. So in conclusion, colon cancer patients who had a healthy body weight, engaged in regular physical activity of approximately 1 hour, 5 days a week, and ate a diet rich in a variety of vegetables and fruits, choosing whole grains over refined, and avoiding red and processed meats, and drinking small to moderate amounts of alcohol, had longer disease-free and overall survival compared to patients who did not engage in these behaviors. Thank you for your time. I'm looking forward to your questions.
Thank you, Dr. Van Blargen. That was terrific. This is Dr. Hayes again, and I want to tie this abstract and the next one you're about to hear together with a few comments. One of those is the optimism we can now present to patients who have early-stage colon cancer. The odds of surviving colon cancer, if it is not metastatic, are quite high these days, thanks to lots of hard work and a number of trials done over the last 30 years showing that adequate surgery and adjuvant chemotherapy improves survival. And the reason we want to emphasize that is that these two abstracts, the one you've just heard from Dr. Van Blargen and the one you're about to hear from Dr. Fadalou, really tell us that that you have a pretty good chance of surviving if you have colon cancer, and that healthy people live healthier. And I know that sounds pretty self-evident, but one cannot assume, oh, I have colon cancer, it doesn't matter anymore. You can assume now, I have colon cancer, and it's pretty likely I'm going to benefit, and therefore I should live a healthy lifestyle, and perhaps might even decrease the chances of my colon cancer coming back, as well as the other health benefits of having a healthy lifestyle. But one thing we very much do want to emphasize is that these abstracts should not be interpreted as suggesting that a patient who has early-stage colon cancer can live a healthy lifestyle and eat tree nuts, which you'll hear about in just a moment, and forego good standard of care. Nobody wants to undergo chemotherapy. We understand that, but chemotherapy clearly saves lives. So people should not interpret these two abstracts as suggesting that if you live a healthy lifestyle and if you eat tree nuts, you don't need to take the chemotherapy that your oncologist would recommend. That's a very dangerous interpretation, and it's not what we're trying to get across. It's that healthy people live healthier. So that's my editorial comment. Now I'm going to turn this over to Dr. Fadalou. Dr. Fadalou is a clinical fellow in medicine at the Dana-Farber Cancer Institute, and he'll present findings from the same clinical trial, actually, in the same study, but investigating the association between nut consumption and colon cancer recurrence. We found this quite interesting. Dr. Fadalou?
Okay. Thanks, Dr. Hayes. Thank you for this opportunity to talk about this work. As Dr. Hayes mentioned, it's a nice follow-up to the prior study around the idea of exploring diet and lifestyle factors and survival in colon cancer. So in this study, we look at the impact of nut consumption and survival in stage 3 colon cancer patients from the same cohort. So the next slide. So states of energy excess are associated with an increased risk of colon cancer death and recurrence. The following factors, including type 2 diabetes, obesity, sedentary lifestyle, Western pattern diet, as well as a high glycemic load, have each been associated with increased risk of colon cancer recurrence and death. The underlying mechanism is thought to be mediated by hyperinsulinemia, as lab values suggestive of hyperinsulinemia, including increased C-peptide, low insulin growth factor binding protein 1, have also individually shown similar associations with colon cancer recurrence. On the other hand, next slide, recent studies are emerging on the benefits of nut consumption. In a large prospective cohort, nut intake was associated with improved overall mortality, and this was primarily driven by benefits in cardiovascular and cancer-related mortality. There have also been other cohorts that have shown that nut consumption is associated with low incidence of type 2 diabetes, as well as a lower incidence of metabolic syndrome and insulin resistance. In addition, in a randomized trial in individuals with high risk of cardiovascular disease, Mediterranean diet with prescribed servings of nuts was associated with lower cardiovascular events as well as lower cardiovascular death. However, the effects of nut intake on colon cancer recurrence and survival is not known. Next slide. So we conducted a prospective study in the cohort previously described. So these are stage 3 colon cancer patients who were enrolled in the CALGB 89803 trial. After exclusion criteria, our resulting cohort was 826 patients. Our data was generated from a validated comprehensive dietary and lifestyle survey that was administered 6 months after completion of chemotherapy. And all patients in the study received surgery and chemotherapy, just emphasizing what Dr. Hayes mentioned earlier. So we assessed the consumption frequency of nuts, individually assessing tree nuts, peanuts, and peanut butter servings. And as mentioned previously, the median follow-up in the study was 7 years. We assessed the association of nut intake with colon cancer recurrence and mortality. And for this study, our primary endpoint was disease-free survival. So next slide. So this slide is a summary of our results. We observed that nut consumption was associated with an improvement in disease-free survival and in overall survival. So on this graph, the y-axis is the hazard ratio. It's a measure of the relative risk of recurrence or death. The colors, orange and green, color code for disease-free survival and overall survival respectively, while the x-axis shows different nut serving categories. So consumption of 2 or more servings of nuts per week was associated with a 42% improvement in disease-free survival and a 57% improvement in overall survival. Of all the patients in our cohort, 19% of patients fell into this category. In our analysis, we also extensively controlled for multiple factors that are known to be associated with colon cancer recurrence. So next slide. So in conclusion, nut intake after diagnosis and standard treatment with surgery and adjuvant chemotherapy was associated with significant improvements in disease-free survival and overall survival in this patient population of stage 3 colon cancer patients. We did a secondary analysis and we observed that the association that was described was only limited to tree nuts. And this association was not seen in peanuts and with peanuts or peanut butter intake. Peanuts are technically legumes, and this difference may perhaps be due to the different biochemical composition between peanuts and the other tree nuts. We don't really know what the underlying biologic mechanism is for this association, but we hypothesize that it's perhaps due to the influence of nuts on insulin resistance. There need to be further studies to really evaluate this hypothesis. And finally, just highlighting that this study adds to the evidence that dietary and lifestyle modification can, in fact, yield protective benefits in colon cancer survivors. Thank you, and I'm looking forward to questions as well.
This is Dr. Hayes again. I want to point out, we'll take questions at the end of all the presentations, but one of the things about both of these trials, or both of these studies, is that while they're not randomized trials, they're observational trials, they were both done prospectively at the time that the clinical trial itself, which was a study of 2 types of chemotherapies for colon cancer, was started. So that takes a lot of the biases out of classic retrospective observational trials where patients are asked, "Do you remember what you did several years ago?" Most of us would not. In this case, it was in real time, and so it makes these findings even more compelling, in my opinion. Having said that, I will move on now. Sticking with the theme of gastrointestinal cancers, our next speaker will detail findings from a randomized phase 3 clinical trial exploring adjuvant capecitabine for the treatment of biliary tract cancer, a cancer that's not very common in the United States, but it's been a very bad cancer and hard to treat. And these are exciting results that lead to an advance. I'd like to introduce Dr. John Primrose, a professor of surgery at the University of Southampton in the United Kingdom, who will present this data to us. Dr. Primrose?
Thank you very much. I'm pleased to present the BILCAP randomized study to you. This is a study on the use of adjuvant capecitabine in patients who've had surgical treatment of biliary tract cancer. Next slide, please. So biliary tract cancer is a less common malignancy. The only curative treatment is surgical resection, but even in that circumstance, most patients will ultimately succumb to the disease. We were interested to know whether the addition of chemotherapy with capecitabine, which is a well-used orally available chemotherapeutic agent, would improve the survival in patients who'd had a complete surgical resection of the disease. So the trial design was we took patients who had surgical treatment of biliary tract cancer and randomized them to either observation only or to treatment with capecitabine in a conventional dosage. The primary endpoint of the study was overall survival, with some additional secondary endpoints. And originally, our power calculation required us to recruit 410 patients to demonstrate a 31% reduction in the hazard ratio for death. Next slide, please. So we started this study quite a long time ago in March 2006, and between then and December 2014, we recruited 447 patients, randomized to observation or capecitabine in numbers 224 and 223, and this was the primary analysis population. As with most large studies, there were a number of withdrawals which we've documented. Next slide, please. So this is the result from the intention to treat analysis. As you can see, the median overall survival was increased in the capecitabine arm from 36 months in the observation arm to 51 months with capecitabine, an improvement of 15 months. When we performed a sensitivity analysis, that is, we corrected for prognostic factors, the difference in the hazard ratio for death was highly significant. Next slide, please. The toxicity associated with chemotherapy was relatively modest, and in fact very similar to what has been observed in other studies. The most common toxicity was palmar plantar erythema, which is basically redness of the hands and feet. There were no deaths related to chemotherapy, and indeed our quality of life analysis showed that there was actually very little difference in the quality of life related to chemotherapy over those who did not have chemotherapy. Next slide, please. So, in conclusion, capecitabine compared to surveillance improved the median survival in resected biliary tract cancer from 36 to 51 months in the intention to treat analysis, and from 36 months to 53 months in the per protocol analysis. The toxicities from chemotherapy were modest, and on this basis, we believe capecitabine should now become the standard of care for patients following curative resection of biliary tract cancer. Thank you very much.
Thank you, Dr. Primrose. It's very nice work. One of the points you have made to me is that these were patients within the United Kingdom. This is a cancer that is much more common in Asia than it is in the Western world. And I think that will be one of the questions that will be raised as to whether these apply to patients from Asia with the same cancer. And I think it'll be an interesting discussion at the meeting. That's not a question for you to answer right now, perhaps later when we get to the question and answer period. But otherwise, this is an impressive study, an enormous amount of work, and a very important finding. So we'll go on now. I'll turn the call over to Dr. Johnson, our president-elect. Bruce, you'll introduce the remaining three speakers.
Thank you, Dan. I'm going to be, our next presentations are going to feature the results of a randomized phase 3 clinical trial of adjuvant gefitinib for patients with non-small cell lung cancer and mutations of the epidermal growth factor receptor. The lead study author, Dr. Yilong Wu, is a director of the Guangdong Lung Cancer Institute of Guangdong General Hospital in Guangzhou, China, and he's going to present the findings. The brief introduction to this is that there's been a decade of research to show that the class of drugs that gefitinib come from have more efficacy in this mutant population than chemotherapy, and Dr. Wu is going to be talking about when you treat patients with earlier stage disease in the adjuvant setting. Dr. Wu.
Thank you, Dr. Johnson. It is my pleasure to hear on behalf of the CTON investigator report this randomized phase 3 trial comparing the gefitinib versus chemotherapy in stage 2 and stage 3A non-small cell lung cancer with the EGR mutation patient. Please, next slide. Please, next. So as you know, approximately 20 to 25 patients diagnosed with the non-small cell lung cancer are suitable for curative surgical resection. And now the adjuvant chemotherapy is the standard of care for patients with the stage 1B to stage 3 non-small cell lung cancer, but only increasing 5% the survival benefit. In recently 10 years, the 9 clinical trials show the EGFR TKI is the standard first-line therapy for EGFR mutation positive advanced lung cancer. So we have to run the hypothesis. So we using the EGFR TKI to replace the chemo for post-surgery lung cancer patient with the EGFR mutation. Please, next slide. So this is the adjuvant study design. We including the patient completely reset the pathological stage 2 and stage 3A the disease, and also EGFR activating mutation. This only including the sensitivity mutation, S19 deletion or the S1025 mutation. So we totally including the 220 the cases. And the stratification affected by the EGFR mutation and the higher the lymph node and the medius node lymph node. And this is the primary endpoint, the disease-free survival. And all the patient with the randomized 1:1, the gefitinib versus the chemotherapy. This next. So this is for the N1 to N2 disease. Please, next slide. This is the result. Gefitinib appeared more effective than preventing recurrence after lung cancer surgery. So please find the totally the journey of the surgery live about 10 months longer without the recurrence than the patient who received the chemotherapy. The median the DFS in the gefitinib is the 28.7 months. In the chemo is 18.0 months. The 3-year the DFS rate in the gefitinib arm is 34% versus the chemotherapy the 27%. Please the next slide. This is the toxicity. They will only report more 10% of the patient. The totally the AE in the gefitinib about 57.5%, the grade 3 only the 12.3%. In the chemotherapy arm, all the grade about 80.5%, but grade more the 3, the 84.3%. The next slide. Please find this is very different toxicity between the chemotherapy and the gefitinib arm. In the chemotherapy arm, most side effect is the neutropenia, annual leukopenia, and then nausea, vomiting, and the nausea. Next slide. In the gefitinib arm, this the very different side effect is raised, elevated ALT, elevated the liver enzyme, and the diarrhea. So this is so very different profile of the side effect between the tissue groups. Please, next slide. So in conclusion, adjuvant therapy can delay the recurrence of the intermediate stage lung cancer after surgery. The 2 years treatment duration of the gefitinib is the efficacy in the tolerability. We have to conclude the adjuvant gefitinib should be considered as an important option for the stage 2 and the stage 3A the lung cancer patient with the EGFR mutation. Thank you very much for your attention. Thank you.
Thank you, Dr. Wu. We'll now hear from Dr. Zhu-Song Han, the Strategic Director of Health Policy and Healthcare, delivering research at the American Cancer Society. She'll highlight the results of a study evaluating changes in the stages at which cancers, those that are detectable by screening, that were diagnosed from 2013 to 2014. Dr. Han?
Yes. Thank you for the introduction, and also thank you very much for this opportunity to present our work, changes in stage at diagnosis of screenable cancers after the Affordable Care Act. Next slide, please. Extensive evidence has shown that people without insurance are more likely to be diagnosed at a later stage, especially for the cancers that can be detected earlier through screening or symptoms. As we know, in 2014, two major components of the Affordable Care Act, Medicaid expansion and the marketplace exchange, were implemented. As a result, insurance coverage has substantially increased for non-elderly Americans. In this study, we want to see, after this implementation, if there are any changes in stage at diagnosis for 5 cancers that can be detected earlier through screening services, as insurance and access to care became more available and affordable. Next, please. Our study subjects were non-elderly screening-aged cancer patients diagnosed in 2013 and 14 from the National Cancer Database, which captures 70% of all cancer cases in the United States every year. The last 3 months of 2013 and the first 3 months of 2014 were excluded as a washout phase-in period. The 5 cancers with screening services available are colorectal cancer, female breast cancer, cervical cancer, lung cancer, and prostate cancer. Here listed the recommended screening age range and the number of patients in our analysis. We compared the proportions of stage 1 disease in 2014 cases versus in 2013 cases, and calculated prevalence ratios adjusted for the basic demographic characteristics. Next, please. Here is what we found. In this left-hand side bar chart, the green bars are the proportions of stage 1 disease in 2014, and the orange bars are for 2013. We see that the percentage of stage 1 at diagnosis increased in 2014 for every cancer except prostate cancer. The right-hand side graph pictures the corresponding adjusted prevalence ratios with 95 confidence intervals. So a prevalence ratio of 1 means no change, less than 1 means decrease, and above 1 means increase in stage 1. We see that the increase in stage 1 diagnosis were statistically significant for colorectal cancer, female breast cancer, and lung cancer, but not for cervical cancer. The decrease for prostate cancer was also statistically significant. So the increase for the first 4 cancers were consistent with our hypothesis, with more people gaining insurance and access to screening services or access to physicians when there are early symptoms. More cancers can be detected at an earlier stage. But what happened to prostate cancer? Next. We think it may reflect the recent USPSTF recommendations against the routine prostate cancer screening. Meantime, we were also curious about if the changes were different in those states that adopted Medicaid expansion and those that didn't. Because in Medicaid expansion states, there are Medicaid available for the low-income people and the marketplace for everyone with premium subsidies or cost sharing for middle-income people, while in non-expansion states, only marketplace was in place to help. Next. So we further stratified the analysis by states' Medicaid expansion status. Here is our findings. Still, the green bars are for 2014 and the orange bars are for 2013. For each cancer type, the upper 2 bars are for Medicaid expansion states and the lower 2 bars are for non-expansion states. We see that although early stage diagnosis seemed to increase in both sets of states for the first 4 cancers, the statistically significant increase for colorectal cancer and lung cancer were only seen in Medicaid expansion states. And for breast cancer, the increase was small but significant in both sets of states.
For prostate cancer, the decrease was seen in both sets of states as well. Next. To conclude our findings, the implementation of the Affordable Care Act was significantly associated with a shift to early stage diagnosis for colorectal cancer, female breast cancer, and lung cancer. We also found a shift to early stage for colorectal cancer and lung cancer were mainly seen in Medicaid expansion states, while the shift for female breast cancer was regardless of Medicaid expansion status. Thank you all very much for your attention, and I'll be happy to answer questions later on.
Thank you, Dr. Han. One of the things that we think this is an important study. Obviously, the changes are not enormous; they're not dramatic. But one of the things that happens is because the uptake of screening is relatively slow. This is certainly consistent with the idea that by doing the additional screening, you can potentially find more stage 1 patients, and the earlier the stage, the more likely a person is to be cured. The other important that ASCO strongly supports is the relative ease of access to screening capabilities, and is one of the characteristics of the Affordable Care Act that most of the cancer screening was covered. And whatever form our healthcare takes over the next several years, we advocate for patients to have early access to screening, which can identify cancers in an earlier stage in the more curable forms. So with that, I'd like to move on now to our last presenter, Dr. Maura Gillison, who conducted the research at Ohio State University, but is now a professor of medicine at the University of Texas MD Anderson Cancer Center. She'll highlight the results of a study evaluating the impact of HPV vaccination on the prevalence of HPV infections, which cause a growing number of head and neck cancers among young adults in the United States. Dr. Gillison?
Thank you, Dr. Johnson. It's a pleasure to be able to present this data on behalf of my colleagues at the National Cancer Institute US and Ohio State University. Next slide. HPV is now appreciated to be the cause of cancers that arise from the tonsil and base of tongue, known as oropharynx cancer. As Dr. Johnson mentioned, it's the fastest rising cancer among young white men in the United States. Over 90% of these cancers are caused by a single HPV type, type 16. HPV 16 is one of the types covered in currently recommended HPV vaccines that have been shown to be safe and effective in prevention of anogenital infections and associated cancers. Vaccines were approved and recommended for girls between the age of 9 and 26 in 2016, and for boys in 2011 between the age of 9 and 21, and up to age 26 for men who have sex with men. But there haven't been any clinical trials evaluating whether the currently approved HPV vaccines can prevent oral infections that lead to cancer, and so that's not currently an indication. Next slide. So we decided to evaluate the impact of HPV vaccines on oral HPV infections among young adults in the U.S. And we did this in a study that we've been doing for the last 8 years in the National Health and Nutrition Examination Survey. This study was restricted to the years 2011 to 2014. NHANES is statistical sampling of the U.S. population, so our data is considered representative of the U.S. population. We chose to focus on individuals, both young men and women between the age of 18 and 33 years in the United States, because they were the first group of young adults who were eligible to receive the HPV vaccine before the recommended age range. So our exposure of interest was self-report of having received 1 or more doses of an HPV vaccine, and our outcome of interest was oral HPV infection with a focus on the 4 different types, HPV 16, 18, 6, and 11, that are covered by the vaccines that were approved before 2016. We collected oral rinse samples from all of these participants. Next slide. With regard to results, 18% of individuals in that age range in the United States as of 2014 reported that they had received one or more doses of an HPV vaccine. And vaccine uptake was higher at this point in women than in men. Only approximately 30% of women had received the vaccine, and unfortunately, only about 7% of young men in this age group. Nevertheless, when we compared how common oral HPV vaccine type infections were in people who had received the vaccine versus had not received the vaccine, in both men and women, we saw a significant reduction in the number of these infections. We were particularly interested in infections among men because this disease, HPV-positive head and neck cancer, is largely, the burden of it's largely borne by men, and the rates are rising most dramatically among men. What we noted was that we didn't detect any of the 4 HPV types among men who reported they'd been vaccinated versus 2.1% of men who had not received the vaccine. So using this data, we estimated that the vaccines could be reducing infections by as much as 88% overall in a vaccinated population and almost 100%, as high as 100% among men. Next slide. Therefore, our data indicate that HPV vaccines have tremendous potential to prevent oral infections. Because this was a national representative sample, we were able to estimate the number of infected individuals in the U.S. population in this age range. In an unvaccinated population, we would estimate that about 1 million young adults would have an oral HPV infection by one of these types. If vaccines were universally accepted, we could have prevented perhaps as many as almost over 900,000 of those. Factoring in, however, the low vaccine uptake as of 2014, we estimated that only 17% of potentially preventable infections had been prevented at that time, 25% in women, and a modest 7% in men. Next slide. In conclusion, HPV vaccines are already strongly recommended for cancer prevention by a number of bodies, including a network of the National Comprehensive Cancer Centers and ASCO. Our data indicate that HPV vaccines may reduce oral HPV infections, but at that time, low vaccine uptake limited the population-level impact of the vaccines. There's considerable optimism, however, because recent data indicate that individuals under the age of 18, 60% of girls have received more than one vaccine, 40% of boys have received more than one vaccine, so vaccine uptake is higher now than it was at that time. We would need further studies. We can't say that this is a cause-effect, the impact of the vaccine on these infections, because this isn't a prospective clinical trial. Nevertheless, we can conclude that HPV vaccination may have additional benefits beyond prevention of anogenital cancers. And I thank you for your kind attention.
This is Dr. Johnson again. You know, one of the things that we're encouraged by this, and one of the first steps in preventing cancer is to first prevent the infection. And this certainly shows within the target population to get vaccination, you can indeed prevent the infection, which is one of the first steps that eventually would potentially lead to cancer. So with that, after these presentations, I'd like to turn it over to Dr. Shulsky.
Great. Thanks so much, Bruce. And I also want to thank all the presenters for really very clear and succinct presentations. So now that we've heard all the presentations, let me just remind all the journalists on the line that the information, again, is embargoed until 5 p.m. Eastern Time today. Please note that the information regarding the presenters' affiliations and disclosures can be found in the embargoed press releases currently posted in ASCO's media headquarters. And if you have questions regarding this information, contact the ASCO media team.